The topic for this presentation is vascular tumors. We'll be discussing orbital varices, lymphangioma, and cavernous hemangioma. Starting with orbital varices. Primary orbital varices, which are combined venous lymphatic malformations of the orbit, consisting of a plexus of thin-walled, distensible, low-flow vein-like vessels that are commonly, though not always, intrinsic to normal circulation. They are probably hematomous. A hematoma is a disorganized overgrowth of a mature tissue normally present in the involved area. Associations include varices of the eyelid, as shown in the figure uh, on the upper eyelid, and conjunctiva. They, as you can see in the lower figure, they are present in the pharyngeal part of the conjunctiva as well. They commonly present at any time from early childhood to late middle age, but occasionally can be acquired later, secondary to a local high flow vascular lesion or trauma. Most of the cases are unilateral, and most frequent site is the upper nasal. Intermittent non-pulsatile proptosis without bruit is reported. If there is free communication with the normal circulation, reversible proptosis may be precipitated or accentuated by increasing venous pressure through coughing, straining, the Valsalva maneuver, assuming a head-down position or external compression of the jugular vein. Imaging, for example, MRI and magnetic resonance venography. CT ultrasound venography shows a lobulated mass with a variable contrast enhancement and may demonstrate phleboliths and sometimes orbital expansion, particularly in childhood or an associated orbital wall defect. The induced proptosis by Valsalva can be seen here. You can see this is pre-Valsalva and this is post-Valsalva in the patients, and this is the mass shown in the scan. You can also see that this is the lobulated mass, and these are the high density phleboliths. Now, complications include acute orbital hemorrhage, thrombosis, which may cause pain, proptosis, and decreased vision, optic nerve compression. Patients with long-standing lesions may develop atrophy of surrounding fat, giving enophthalmos with deepened superior sulcus. As you can see here, the sulcus here is deepened, and it seems like that upper lid is bigger than the other eye. Now, small lesions generally do not require treatment. Surgical excision is technically difficult and often incomplete because the lesions are friable and bleed easily. It can be complicated by severe orbital hemorrhage and vascular optic nerve compromise. Specialized techniques such as embolization and carbon dioxide laser surgery may be helpful adjuncts. Indications include recurrent thrombosis, pain, severe proptosis, and optic nerve compression. Now, lymphangiomas is a rare hematomous vascular tumor that tends to enlarge and infiltrate diffusely with time. Some authorities believe lymphangiomas to be a variant of venous orbital anomaly. Varices across a single spectrum, and the term combined venous lymphatic malformations of the orbit has been suggested. Although usually isolated from the main circulation, bleeding into the lumen may occur with subsequent formation of the blood-filled chocolate cysts that regress spontaneously with time. Presentation is usually in early childhood. Differential diagnosis is principally from the orbital venous anomalies and hemangiomas. Intracranial vascular malformations can be present in association. Now, anterior lesions typically manifest as several soft bluish masses in the upper nasal quadrant, as you can see here in this child in the left eye. Posterior lesions may cause slowly progressive proptosis, as you can see here in this child's eye, and they may lie dormant and later present with sudden onset of painful proptosis secondary to spontaneous hemorrhage, which may be associated with optic nerve compression. Involvement of lids, conjunctiva, and oropharynx may be seen. Intracranial lesions may be present. Now, this axial MRI also shows the presence of lymphangioma in the lid retrobulbar area here, and you can see that this is not present in the other eye. In many cases, the visual prognosis is good without treatment. Surgical excision is difficult because lesions are not encapsulated and they are friable, bleed easily, and commonly infiltrate normal orbital tissues. Repeated subtotal excision may be necessary. Persistent sight-threatening trochlear cyst can be drained or removed subtotally by controlled vaporization using a carbon dioxide laser. Now, cavernous hemangiomas occur in middle-aged adults with a female preponderance of 70%. The growth may be accelerated by pregnancy. It is the most common orbital tumor in adults and is probably a vascular malformation rather than a neoplastic lesion. Although it may develop anywhere in the orbit, it most frequently occurs within the lateral part of the muscle cone, just behind the globe, and behaves like a low-flow arteriovenous malformation. Histology shows endothelial-lined vascular channels of varying size separated by fibrous septa. As you can see here in the histological picture, these seem like uh, uh, congested, variably sized endothelial-lined vascular channels. Now, diagnosis is based on symptoms, signs, and investigations. It is a slowly progressive unilateral proptosis, which bilateral cases are very rare. Axial proptosis, which may be associated with optic disc edema and choroidal folds. A lesion at the orbital apex may compress the optic nerve without causing significant proptosis. Um, Gaze-evoked transient blurring of vision may occur. You can see the axial proptosis in this cases as in the figure. You can see there is right proptosis in this eye, which is quite clear. Now, CT and MRI show a well circumscribed oval lesion, usually within the muscle cone. There is only slow contrast enhancement. Ultrasound is also useful. You can see it here, a well circumscribed lesion which is present retrobulbar in the retrobulbar region in the muscle cone. And now, many cavernous hemangiomas are detected by chance on scans and performed for unrelated reasons, and observation alone is often appropriate. Symptomatic lesions require surgical excision in most cases because they gradually enlarge. The cavernous hemangiomas, unlike its other counterparts, is usually well encapsulated and relatively easy to remove, as it is shown in the figure here that it is quite easy to remove, and surgical excision is done. So that's it with the orbital vascular tumors. If you like the lecture, please click on the like button and subscribe to the channel. Thank you very much.